Good morning, colleagues. Just going to wait maybe 2 more minutes to just see if we can allow a few more people to get into the meeting. And then after that, we will be off. Thanks. Good morning again, and welcome to the Wednesday meeting. I will not waste much time. I'll introduce our speakers for today. And I know that the theme is quite cryptic for all of us, especially if you don't know the language in which it's been phrased. So today's presentation is going to be done by 2 of our APFP fellows. It's going to be led by Tamanda Hiwa and supported by Beatrice Phiri, and it's entitled Takula Ndirani Masukani, and they will explain what that means. Tamanda, you ready to share? And you can take it on from here.
Good morning, everyone. As Prof said, my name is Tamanda, and I'm here with Beatrice this morning, and we're going to take you through this presentation titled Dagulandirani Masukani. So we are APFP General Pediatric Registrars from Malawi, and this title is in our native language, Chichewa. Dagulandirani means welcome, and Masukani means make yourselves comfortable or be at ease. Um, so welcome, and we hope you enjoy our talk. So I'd like to take this opportunity to welcome you on board Malawian Airlines flight PEDS QECH 101. I'll be your captain this morning, and Beatrice and I have the privilege of taking you on a short trip to a place where we call home. So we hope you enjoy our flight. Make yourself comfortable. We're just going to take you through to the warm heart of Africa and give you a glimpse of pediatrics at Queen Elizabeth Central Hospital. So this is an article from August of, is it 1986 or 1987, showing a picture of a 7-year-old boy that presented to our first ever cardiothoracic surgeon, who unfortunately died last week. With having, apparently was playing with a needle and it got stuck in his chest. They had tried to operate on him to remove the needle at Kamuzu Central Hospital, one of our central hospitals, and wasn't successful. And the boy had to be flown out to our wonderful Red Cross War Memorial Children's Hospital to have cardiothoracic surgery. And that's a picture of a nurse who came with the child, and he had the surgery was a success, and this was a picture of them going back to Malawi after the heart surgery. So clearly, Red Cross, War Memorial Children's Hospital, and Malawi have been friends for quite a long time. So this is a picture just showcasing where Malawi is in the map of Africa, and our beautiful lake. That's a picture of Likoma Island. And then we have our wonderful elephants at Liwonde National Park, and that shows the magnificent Mulanje Mountains with the tea plantations in the background. So looking at the public healthcare system of Malawi, that map is showing the circles are showing the district hospitals. We have about 28 districts. The 28th district hospital is still being built, and that's Palombe. And the diamonds are showing the 4 central hospitals that we have, and we come from Blantyre, which is number 23, somewhere closer to the bottom in the southern region of Malawi. So in terms of a public healthcare functionality, our central hospital in Blantyre is called Queen Elizabeth Central Hospital, and that caters for as a tertiary referral site for the district hospitals in the south, as well as also subspecialty referrals from the other central hospitals for fields where we don't have a specialist in the other central hospitals. So going down to Blantyre, that picture is showing Blantyre. I don't know how well it's projecting. It's Blantyre pointing out all the health facilities that are in Blantyre district. And our central hospital is somewhere, I don't think you can actually see it. It's a star somewhere around the gray area. So unfortunately, Blantyre as a district does not have a district hospitals, but we have about 24 primary healthcare facilities that therefore refer all the secondary level admissions to Blantyre district, as well as Queens also, as I said earlier, taking in all tertiary level facility referrals from the other districts in the southern region. So we have, according to the National Statistics Office, our population for Blantyre district is about 1.5 million, and infants make up about 75,000 of that population, with under 5 being about 250,000, and under 15 being just close to half of that population. As you can see, we're quite a very young population. And expected deliveries for this year projected to be 75,000. This is the home of the Pediatrics and Child Health Department at our College of Medicine. At the bottom right is the area of view of the college. And the top right is our library building, which was built in memoriam of the first doctor who championed the founding of the College of Medicine, Dr. Chipangwi, who was an obstetrician and gynecologist. And welcome, this is Queen Elizabeth Central Hospital. The gray building is the Adult Accidents and Emergency Department, which is the main entrance of the hospital. And this is the outside of our pediatric department, and that corridor is where we get grilled, where you get presentations, and where our wonderful department offices are. And the top picture is showing some of the members of the department. Joe, you're probably wondering why there's such diversity. I think we have one of our heads of department, Dr. Queen Dube, who is there kind of kneeling, but squatting, but not really squatting. And some of those are members of the team from Malawi Liverpool Welcome Trust and some visiting volunteer registrars. And I don't know if you can pick up Dr. Messi Kumwenda, who is also here, who is standing just next to the balloons on that photo. And now I'm going to take you through the wards, and starting from where the magic happens. That's the Accidents and Emergency Department. That's our entrance to the Pediatric Accidents and Emergency Department. We have a nurse who does the triage, and then we have a resuscitation room where it's a 2-bedroom, but it can take an infinite number of patients at a time. We have about 4 consultation rooms that deal with the outpatient more of the ambulatory patients. We also have a minor theater on site to attend to small wounds, fractures, and other minor traumas that come in. And as you know, we're malaria endemic country, so we have an on-site lab that does malaria tests as well as packed cell volume, which is a hemoglobin estimation for all patients that need it that come into the A&E department. We also have a short stay ward. And I'm going to talk about that in the next few slides. As you can see, COVID came and COVID happened, and we had to find a way to social distance in the waiting area. And that's Dr. Joe Langton, who coordinates the registrar program in Blantyre. And that's the entrance to where most of the magic happens, in the resuscitation room. And that's one of our consultation rooms. And those are the nurses, that the magnificent nurses we work with in the A&E in PPE, thanks to COVID. So our short stay ward was mostly for patients. We do not admit patients overnight due to staffing problems. We have one nurse who monitors the patients, and the registrars and the interns working in A&E have to go in and reassess the patients and make a decision around 3 p.m. before the handover round on who needs to get admitted to the wards and who needs to be discharged. Usually it's just patients that require monitoring for a few hours that maybe you're really not sure when they come in. Mostly it's kids with acute gastroenteritis with some dehydration that you're giving oral rehydration, and then you assess whether they're fit to go home or they need admission to the ward. But since coming in of COVID, now this has been converted into the respiratory zone, which looks after the PUIs and COVID positive children. And then I'll take you down to the ward. So we have a pediatric nursery that looks after infants under 6 months, and this is those that have been discharged from hospital. It caters for both surgical and medical admissions. And we have a high dependency unit and floor. We have about a 14 beds, but the number of beds expands according to need. So you can have more than 14 patients in there. And we offer CPAP and oxygen. And all those babies that are on IV fluids will be in the high dependency unit. And the common causes of admissions to a pediatric nursery are babies with neonatal sepsis, acute respiratory illnesses, congenital heart disease, as well as surgical conditions. Then pediatric special care ward, I think if you ask anyone, they have a love-hate relationship with this ward because this is the craziest ward. It's general pediatric admissions older than 6 months. So, well, it depends how small you are to determine your cutoff age for admission to the pediatric ward. Mostly, we have acute respiratory illnesses, acute gastroenteritis, malaria, TB, and a concoction of cardiac conditions, mostly common rheumatic heart disease and some congenital cardiac heart disease that were not diagnosed earlier. And this is where a lot of the magic happens. This ward sometimes can have up to 70 to 80 patients or more, depending on whether it's a peak season or it's a more quieter season. Then we have medical bay. It's a 20-bed ward. This is more of where we look after the chronic medical patients. So acutely, they'll be in the special care ward, then they get transferred to medical bay when they're stable. And mostly it's patients that still need wake up, or those that are getting long-term treatment, whether it's long-term antibiotics, patients who are undergoing rehabilitation, mostly will be in this ward. And then we have the Moyo Nutritional Rehabilitation Unit. This is where all our malnourished babies are admitted. So we have a 4-bed high dependency unit. And then they get, when they're more stable, they get moved to, we have a mini HDU and then the main floor patients. Most causes of admission are HIV and its complications, cerebral palsy, kids with other underlying medical illnesses that present as being malnourished, and also those coming in due to food insecurity or poor socioeconomic status. What's special about this ward is that it's formulated to be comfortable for babies with severe acute malnutrition. So we have the big beds to ensure that the mothers and the babies can lie together. The room is warmed up, and we have special nurses that are trained in the nutrition, and we have the special feeds that are actually made on the ward to cater for the frequent feeding times. So we try to ensure that all kids that are picked up on admission to be malnourished will all go to Moyo ward. And then we have the pediatric oncology ward, which is a 20-bed unit. And our most common causes of admissions are Burkitt's lymphoma and leukemia. We do have several Wilms tumors as well as germ cell tumors. We only offer chemotherapy, and together with the pediatric surgeons, we have, for those that need surgery, they have a surgical resection. We've just opened the National Cancer Center, and we're hoping that with time we can be able to offer radiotherapy to the Malawian population. But those that can manage, sometimes they can be referred to Tanzania to go for radiotherapy. And then Chadinkanesa is our neonatal unit. So it's a combined neonatal and KMC unit. As you can see, I've said there's 34 plus bed units because, as I said, coming here, the first shock I had was being told that the ward is full. And at first, initially, I didn't understand that wards could be full. But this is our reality back home. We have about 350 admissions per month, and our most common cause of admission is maybe in the top 5, prematurity takes the top 3. And then we have perinatal asphyxia, neonatal sepsis, and down the line, congenital anomalies. So this is showing, the first picture is showing our hot cot, the wooden cot, because initially we had lots of babies with hypothermia, and we're trying to figure out how to deal with that. So with our friends in the Polytechnic and some other people in the department, they devised these hot cots. So if you can see, I don't know if you can see my pointer. There are these bulbs at the bottom. So basically, there's this cot, it's a wooden cot, and then there's a plank that separates the bottom to where you put the mattress. And underneath, right at the bottom, there are 4 light bulbs that then provide. So we use the light bulbs to provide heat to keep the babies warm. The only downfall is that it doesn't have a thermostat. So you have to continuously check the babies to make sure that you don't overheat the babies. And the sockets then control how many light bulbs you're gonna switch on. So this made a huge improvement, especially in our preterm babies that were suffering from hypothermia. Currently, we're working with the Polytechnic to try to see if we can make a version that then has a thermostat and can control the temperatures and switch off the light bulbs when the baby has warmed up. So that's quite exciting. The bottom picture is showing the nurses in our KMC unit. As I don't know if most of you are aware, Malawi is one of the top countries in the world with the highest rates of premature birth. This is a picture showing a high dependency unit of the neonatal nursery, and also showing the hot cots that I was telling you guys about. And the other day I was having a conversation with some of the registrars, and we were talking about sharing oxygen, and they were a bit surprised that, oh, how does it, okay, firstly, they were asking about what an oxygen concentrator is. And I was telling them that, yeah, sometimes we have to split oxygen between patients. So if you see, this is an oxygen splitter with the individual flow meters that then regulate how much oxygen you're giving to each patient who is connected to each one of the patients with the flow meter. And next to it is our Pumani CPAP machine. So this was a low-cost CPAP machine that was also made in conjunction with the Polytechnic to ensure that it's a low-priced CPAP machine so that we could be able to get CPAP machines for our babies in a low resource setting. So currently we've managed to scale up CPAP to all our district hospitals. And we're planning to then try to get more CPAP machines for each of the hospitals to improve our neonatal and infant outcomes. And well, I think that's a closer view of the Pumani CPAP. Basically, this is a water, this bottle has water in it with marked levels, or depending on how much pressure you want. And then one of the knobs regulates flow and the other one regulates the rate of oxygen. One of this connects to the oxygen, and this big pipe is what connects to the nasal prongs that go onto the baby. I think it's just not a clear view, but this is one of the babies actually on CPAP. And then thanks to Madonna and lots of other people that helped to fund the building of the Mercy James Center for Pediatric Surgery and Intensive Care, because now for the past 2 years, Malawi now has the first pediatric ICU, whereas before pediatrics was sharing with adults in the main ICU. So the PICU has 6 beds that are shared between surgical and pediatric medical, and that has really improved outcomes for pediatric surgical babies that needed ICU, as well as pediatric medical admissions that also need ICU. So these are just some pictures from our PEDS ICU and the surgical ward. And then we also, as the registrars, we also rotate in outpatient clinics with our consultants. That's the list of the clinics that you have to do during each of your rotations. You're assigned to one of the clinics. And that's one of our registrars in COVID attire going to the outpatient clinics. So I think we also have collaborations with the department with other research institutions. I'm only going to talk about 2, but there's several. That I think just to outline that sometimes, even though we're in a low resource settings, there are other institutions that might have some resources, and with good collaboration, we're able to benefit not just on the research aspect, but also even the direct care of the patient. So for example, the Blantyre Malaria Project does malaria research during malaria season, and they've been doing this for years. But they also have other resources like that they do as part of the research that together with the department, they're able to help us with getting things like EEG. The lab that is in A&E that does malaria tests is manned by staff from the Malaria Research Project. And also the clinical staff also help with clinical work in the wards outside of the malaria season where they're doing the research, as well as the Malawi Liverpool Wellcome Trust and Johns Hopkins University. They also help with lab resources. So we're able to do some things that are not offered in the public health service. And also being research institutions, they also help with our supervision of inmates, and also they try to mentor us in terms of research. In terms of, so the hurdles that we have, lack of resources, being a low resource income country. So lack of resources, we're unable to do some of the investigations that we do. Luckily, with some collaborations that Tamanda is going to talk about, we have some sponsors that are able to give us resources that either go into buying drugs that are not available in the public sector, so especially like cardiac drugs, as well as some funds for targeted investigations in private. We have shortage of staff. I think that's common everywhere. And also the high mortality, sometimes it really takes a toll on us, and the high patient numbers that sometimes can be overwhelming. And then Tamanda is going to take you through the rest of the presentation.
Beatrice did all the heavy lifting there. I'm just going to come in and try and take us down on a lighter, softer, smooth landing. I strongly believe that all work and no play should not exist with pediatricians, because it just makes pediatricians really grumpy people. So if you look on the left there, there's a picture of me goofing around in our resuscitation area when we had no patients, just to lighten up the load on that day. And on the right there, there's a picture of a group of us, and you can see Jo at the back there. I'll show her to you again later on, and she's joined our talk this morning. She supervises the registrar program. We call her our mama bear, and she's our previous head of department of the pediatric and child health department under the College of Medicine. So we try and encourage us getting together outside of work hours as a registrar body, but also as a department, to try and get to know each other better and to carry out a few team building exercises. So that's us at one of the dinners that we had together. I'm sure you could recognize some of the faces that are in the picture, and the others are some of the volunteer registrars that come and join us. Most of them tend to come from the United Kingdom and Germany. We like to try and bring a little cheer to the little ones on the ward as much as we can, and usually Christmas is the easiest time to do that. Some of you know George. He's our pediatric oncologist at Queen Elizabeth Central Hospital. He came in last year as Santa Claus, and Jenna here, who was here practicing in the ICU for 2 years, a couple of years ago, was his happy helper, and they brought some cheer to the patients on the ward and to some of the staff members as well. But last year was a very special Christmas because we managed to get a super special Santa come and visit us as well. This here is the current Vice President of the Republic of Malawi. He came in with his lovely wife, and they came in with a couple of cabinet ministers just to bring some good cheer to the patients on the ward over Christmas. Practicing pediatrics in a low resource setting is very difficult to do, and sometimes you have to go an extra mile just to make things happen. You see in this picture Dr. Josephine Langton, who I talked to you about earlier. I'm painting the chairs in the A&E department just to try and see if we can manage to get some distancing done during this COVID season. And a lot of help was done in support with some of the organizations that I'll talk to you about, helping raising funds to come and help our situation. The picture on the left here, this was one of the events that took place in 2019 as we were trying to raise funds for one of our organizations that supports us as well. It was a very grueling task getting Jo to run 42 kilometers. And this was us helping support her to get to the finish line. So the first organization I'm going to tell you about is the Friends of Sick Children, and it works under the Friends of Sick Children in Malawi, which is a British-based organization. It's a charity that helps in raising funds to help support education, staff members, and money to help with the investigations that Beatrice talked about, so that we can get some tests done in private labs when we cannot access them in our own hospital labs. So some of the people that they help fund is they provide salaries for some of the nurses on the wards and other healthcare assistants. They also provide for a teacher who helps in teaching the kids that are in the hospitals for a long time, mostly those that are in the oncology ward and the medical bay as well. Most of the funding from FOSC, as I said, comes from the United Kingdom, but we tried in 2019 to raise some funds locally as well. So we decided that we were going to carry out different kinds of marathons to raise funds. Jo managed to raise £7,000 as she ran 40 marathons that year. We also had a yogathon, and we had a bikeathon in the department where we took stationary bikes and we had patients and registrars cycling the distance from the north of Malawi to the south. So it's about 1,100 kilometers, and we managed to cycle from the north to the south and back to the north again. And it was a really great time. Everybody enjoyed themselves, and we managed to make some money as well. The next organization I'm going to tell you about is the Pediatric Association of Child Health in Malawi. It's basically a body of pediatricians, and what they look at is helping in training, um, resource mobilization, research support, and advocacy. And their aim is basically to deliver great healthcare to the children in Malawi. We recently started having conferences, and we've had 2 conferences so far. We try to do them biannually. So the last conference was in 2019, where we looked at promoting surviving, thriving, and transforming. Ideally, we should have our next um, conference this year, COVID allowing, and it would be great if some of you were to try and come and join us, whether it will be in person or online. So the organization also works really closely with the department at Queen Elizabeth Central Hospital, and on the World Preemie Day last year, they decided to paint the wards purple. So these are our lovely healthcare workers, nurses, clinicians, in the department after the morning meeting and in the ward on that day, having a little fun. You can see some of you know Dominic. He just recently finished his time here on the right there. And what's Preemie Day without our lovely KMC mothers and our KMC babies here in our KMC unit at Chattinka Nursery. The last organization I'm going to talk about is the World Child Cancer, which I'm sure a lot of you know about. It's a British-based organization that basically helps in healthcare training and resource mobilization for children with cancer in low and middle income countries. We work closely with them at Queen Elizabeth Central Hospital, and some of the things that they help us with is helping us with money for investigations. We're able to run a blood gas analyzer, and we now have a full blood count machine in the department, mostly for the oncology patients, but the whole department benefits from that as well. The other thing that they help us with is being able to help with cytology review. So we'll collect bone marrow aspirates and FNAs on the ward. Our lab tech will prepare the preparations and slides, and we take pictures of them under a microscope and send them to the UK, where oncologists and pathologists look at them and help us making diagnosis. Another thing we try to do with the kids on the oncology wards that they help us with is try to have a little fun with them. And every year on the 15th of February, on World Child Cancer Day, we try and throw them a party. In 2019, we decided to take things a little bit further and decided to do a little bit of an awareness campaign. We had a big walk with some of our oncology patients that you see in the picture on the right, some survivors as well and their guardians, and it was a lot of fun. Basically, a lot of people in Malawi think cancer is as a result of being cursed. So we try to raise awareness, allow people to know that it's not that you have being cursed, that the child is unwell and you need to refer them to the hospital as soon as possible. On that note, I'm going to finish off by talking to you a little bit about a campaign that the Pacha is doing. I'm going to try and play this video here. So with the worrying increase in child abuse that we're seeing in the country, the Pediatric and Child Health Association of Malawi, in commemorating the World Children's Day last year, they started a campaign promoting children's rights under the theme Hands Off Our Children. And basically what they're trying to do is put the spotlight on children's rights in particular, and to address some of the effects of COVID as well. So there are some prominent figures that were in this clip that I just showed you now with their messages to the nation. We have the Vice President's wife that you saw, one of the Supreme Court judges, and a few other celebrities from Malawi just raising their hands to try and fight against abuse towards our children. And one of the people in the clip there is our current acting principal of the College of Medicine, Prof. Mark Malewa, that some of you might know. He is a professor of pediatric neurology. On that note, it has been a pleasure flying you this morning, and we hope you enjoyed the trip as much as we enjoyed taking you on the ride. And we hope that you can strongly consider coming to visit us one day to see what it is like to practice pediatrics in the warm heart of Africa. Thank you very much.
Thank you. Or as you say, zikomo kwambiri. You're still sharing, Tamanda. Again, thank you for that, eye view and the flight to Malawi. Greatly appreciated for us to be able to see where our members of our community here come from, and we really appreciate that. Are there any comments or questions that people would like to ask Tamanda and Beatrice? Maybe I can start the ball rolling. So I'm just, you were showing this slide with a lot of people from off continent who are spending time in Malawi. I just want to know, what do you think about the potential of registrars coming from this place, from UCT and the Red Cross War Memorial Children's Hospital, coming to Malawi to learn from you? If all these Europeans are coming to Malawi, obviously it means there's something that you have to offer in that space which is different from their experience. Do you see any value at all that could accrue from us having, if it's all feasible, doing something of the sort with our registrars coming from here to come and learn in a different environment, even if it's for a brief moment?
Thank you, Prof. I think that would be a great idea. I don't know if Jo is still on the line. Maybe she could respond more to that, because she works very closely with getting the volunteer registrars to come in. But if you were to come and work as a registrar in Malawi, you get to see that things are done very differently, and there's a lot that can be done with minimal resources. You get to see some conditions that are different from the things that you see here, but also you learn to work and be able to be comfortable working on your own on the wards, because a lot of the times our consultants, we have short of consultants on the ground, and we have to learn to manage the wards to the best of your ability, and be able to be confident to do it very early on. So I think it would be a great thing to try and get that with the registrars here. Jo, would you like to say something in addition to that? Jo, would you like to say anything?
I think Jill may be muted.
Oh, sorry. Hi. Hello. Some of you I know, some of you I don't know, and apparently I'm the registrar's mama bear. So I think this is an excellent suggestion. I actually myself came to Malawi as a registrar, and if I hadn't been here as a volunteer, I categorically would not have got into paediatric emergency medicine. So my year, which I spent in Malawi volunteering, actually ended up counting for my training in the UK. So it was recognised to be of a high standard, and it was the basic premises for me to be able to get into paediatric emergency medicine. I would not have got in otherwise. I think, as Tamanda has said, there's huge amounts to gain from coming to a setting like Malawi. We have a robust training program. We have a lot of very interesting patients with quite interesting pathology. And one of the things which you develop here is really good clinical acumen. So you have to rely on your clinical skills and your clinical diagnostic skills, because we don't have the investigations available to be able to help us and augment the diagnostic process. And it also helps you to learn how to manage clinical uncertainty because there is a lot of uncertainty in what we're doing and we're having to rely on our clinical judgments. So we've had a long-standing partnership between Malawi and South Africa, and specifically between Queen's and Red Cross, and also with the APFP. And I think it would be great to have people come and learn from the environment which our registrars learn in.
Thank you very much for that. Again, really shows great opportunities for us to learn from each other. And in fact, I think it allows us to realize that where people are inclined to see themselves as sort of givers, actually fail to see how much they can be recipients of great learning opportunities if they actually see them as such. Are there any questions from anyone? Can't see any hands at the moment. Is there anyone who wants to ask any question or comment anything? I think there's a hand raised. I can't see whose hand it is. You can just jump in.
It was me, Ruth. It's Elvin.
You can just jump in, Elvin. Please, thank you.
Hi. Ruth, I'm not sure who was supervising the talks, but I think it was a very timely and a fantastic talk. Just to say thank you to the speakers for much excellent talks, and just want to echo the gratitude that you said in Chichewa, Chikaponya-Phiri. And so we thank you very much for that. I think the insights gained from talks like this are very important for, I think, not just fostering better relationship with peers here, but with supervisors, and I think knowing where part of our society comes from is very helpful in assisting us with the lens through which we look and we deal with each other. I think from a registrar team's perspective, I'm just very excited about the progress that's been made by the Malawian training. I think over the years, I think now they're coming for a much lesser time for rotation here, and I think Malawian training for pediatric specialization is kind of coming out, and I think soon is going to be very independent. I think the future is such that I think for us, it's very important to learn some lessons from Malawi. I saw from Tamanda's presentations, I think one of the first things, it looks like it's a very fun place to be. There's a lot of fun to be had in that environment. I think we can take a leaf and learn a lot of lessons. The conversation that you raised, Ruth, about the possible elective time, it may be 2 weeks or 4 weeks, or I know that there may be logistical constraints about the relationship, but that conversation has happened before, and I think it should be encouraged to happen, and rather than looking at obstacles and actually looking at how we can overcome those obstacles to make that possible. It's a fantastic opportunity for broadening our world pediatric view for our registrar training. I think it would be a fantastic opportunity. Again, Chikaponya-Phiri, thank you very much to the speakers.
Thank you, Budalvin, for that comment. I don't see any other hand here. And again, just if there's no one, I just want to express our gratitude again for this talk and for, in many ways, opening our eyes to what is out there, as well as understanding each other and the community that we form here in Cape Town today. So I think if there's nothing else, Kirsty, do you have any announcement or anything? There's still a bit of time for that. If not, I'm happy to close or die. Do you have any announcement or anything?
Hi, Roots. Just to remind people about next week's talk, which will be focused on vaccines, and just for those who were on the talk earlier this week, the idea behind having another talk next week is more around broadening the platform. So we will obviously circulate the details of that towards the end of this week, but we'll encourage everybody to you know, to pass on the details of the talk for anybody across the platform who's interested.
Thank you very much for that. I think that, I mean, this is really becoming more and more important with the imminent vaccination program being enrolled through the country and starting with healthcare workers. So again, I'll encourage all of us to attend and to get other people to attend to. With that, thank you very, very much. And thank you for making the time to attend this morning's meeting, and see you again next week. Thank you.